sharing the story of a middle aged lady who was twice lucky. Welcome to Stroke Rounds.
In October 2016, she came to the casualty with sudden onset of right upper and lower limb weakness and facial deviation to the left of around 90 minutes duration. She was having atrial fibrillation for the past 1 year and off medication. On examination, she was having aphasia, right upper limb rate 0 power, lower limb 3 by 5 power.
What will you do immediately?
We will evaluate for stroke and we will shift the patient for immediate CT scan.
So there is absolutely no doubt, no? It is lateral fibrillation, 1 year off medication, aphasia, then hemiplegia. So it has to be an MN occlusion unless proved otherwise. So you have to look carefully in this particular cut. What do you see?
In the plain CT, we can see there is a left dense MCA sign
It is
and
not very dense, but
yes,
still
no,
you can see the dense. So you
yes.
have to look carefully in that region to see, and it is extending into the bifurcation. It is extending into the Sylvian fissure where it is dividing into two branches. Immediately the patient underwent a CT angiogram. So this is the left, and you can see the M1 cut off, a small branch coming distally, but now the M1 is completely cut off here. So what should be done immediately?
Patient,
So the patient has a multi-phase CT also showing that there is a good collateral. So that means this is an ideal patient because collaterals we always discuss. It is like an ambu bag trying to perfuse and keep the neurons alive in the area which is occluded. So that doesn't mean that nothing will happen. These collaterals will eventually die. It is like an ambu bag. You can keep it alive only for a short period of time. So in the meantime, you will have to reperfuse them. What should be done immediately?
mechanical thrombectomy.
Before that, now the patient is always on the CT gantry. So the first thing is always you are not very sure now whether you will be able to do mechanical thrombectomy. So always now, and the patient has come within in the window period. So whether you are able to do thrombectomy or not, always don't disregard the option of IV thrombolysis. That is eminently shown by this particular patient. The patient was immediately given, started on Actylize, and the patient showed a gradual improvement. Because of certain reasons, I think it was because of financial reason, the patient could not afford a mechanical thrombectomy, and the patient started showing improvement immediately. So the patient was not taken up for thrombectomy, and the patient made a complete recovery. So this is a typical example of a patient with an M1 occlusion where IV thrombolysis alone recanalized the vessel completely, and this is the follow-up CT scan without any major infarct. You can see that the dense MC also has disappeared, showing that you don't need a CT angio now to prove that the M1 has opened. The MCA has opened up completely. There is no major deficits. The patient has. So this is an eminent example proving the point that never disregard the benefit of IV thrombolysis in a patient with M1 occlusion. So the patient, because nowadays with the tenecteplase, you can give the injection immediately in the CT gantry itself. So without thinking, within maybe 1 minute or 2 minutes, you can give the thrombolytic drug in the CT gantry itself. And rarely, I'm not saying that every patient or 50, hardly maybe 10% of the patients will have a spontaneous recanalization because of IV thrombolysis, and they may not need a mechanical thrombectomy. Now, the rest of the story.
On further follow-up, patient was discharged with antiplatelet and NOAC, and we lost the follow-up for around 2 months. And in August 2018, that is after 2 years, she once again developed sudden onset of again right side weakness of 1 hour duration. In between, she gave a history of acute coronary syndrome and angioplasty was done. And in between, this NOAC was stopped because there was reversion of atrial fibrillation, and she was only on dual antiplatelet. And on examination, she was again having aphasia, right upper limb 1 by 5 power, lower limb 2 by 5 power, and injection tenecteplase was given after plain CT. This was the plain CT showing once again showing the left.
So this is the patient coming back in 2018 again with the same M1 occlusion. So you see again that there's a dense MCA sign. You can see what is this sign called? MCA dot sign. So again, the patient underwent a CT angio which showed that the M1 is occluded, but there is good collaterals distally. See that there's an M1 occlusion. You can see the M1 occlusion, and in this the multi-phase CT, you can see that the collaterals are good. M1 occlusion. So the opposite side is good. There is no cross flow. You can understood, no? The ECOM is not patent. So this is not supplying this side. So this is the left common carotid injection showing that this is the Internal carotid artery, petrous segment, cavernous segment, distal ICA. This is the A1, which is very, very small, and M1 occlusion. You can see it very here. There is an abrupt cutoff suggesting that it is a thrombus. You can see the cutoff very clearly here. And this is the antecerebral artery. It's a very small antecerebral artery. So what was done? The patient was taken up for mechanical thrombectomy. This is the guiding catheter here. An aspiration catheter was slowly taken up over a microcatheter. It was taken distally into the vessel, and with aspiration, the vessel completely opened. Understood. So what? But now you shouldn't be very, very happy, just by seeing that the vessel has opened. You should carefully examine the angiogram after that, which showed that there is traces of contrast in this branch of MCA. So that means that there is a small fragment has gone distally and it is occluding the one of the branches. You can see it again here that this branch is occluded. So study that area properly. Even though this is occluded, there is a pile collaterals and retrograde filling into that area which is supplied by this branch, showing that there is perfusion here. But what are the options now? This is a very, very small branch. You can't go in there and do a mechanical thrombectomy. It's very distal. One of the option is to
Very small microcatheter
can be taken
introduced
distally into this branch.
and give
You need not take it this distally. You can take it into as distally as possible and give IV intra-arterial thrombolytic. The other is to wait and see, because the perfusion has started. So the blood itself, each systole, there is a chance that it can push the thrombus away, because it's a fragmented clot. It is not a big clot, because normally the clot gets stuck in the M1 because of the bifurcation. So it is a large clot. You have aspirated the clot and it is fragmented. So it is a fragment of the clot got dislodged and stuck here. So the chance of it spontaneously lysing also is high. So you wait for 5 minutes and repeat an angio. You see that the vessel has completely opened. You see all the branches clearly. So that small fragment which was there. So this is in comparison here, it is occluded, and this is the angiogram showing that there was a branch occlusion and it is spontaneously recanalized completely. So this is the picture which shows the aspiration catheter at the site of the clot recanalization, and this is the CT scan showing that there was mild diffusion restriction in the lenticular striate territory, because it's a monocclusion. The lenticular striate were temporarily halted. Why this happened? Why there was no diffusion restriction in the periphery, but there is mild diffusion restriction in the
was there initially
where
in the cortex
periphery? But what about lenticular striate?
in that
Lenticular striates are end arteries. Lenticular striate arteries doesn't have good collaterals. So that is why probably the diffusion restriction is seen in the area of lenticular striate, but not in the area of cortical branches. But fortunately, she did not have any deficits, and she came for follow-up like this without any deficit. She was completely normal. She is continuing on anticoagulation, oral anticoagulation. So this is a lucky lady who had stroke, M1 occlusion twice, initially recanalized with IV thrombolysis alone, but second time underwent mechanical thrombectomy, and without any major deficit, she is surviving. Thank you. Please do share your comments, thoughts, opinions, and if you have any more suggestions to improve this stroke rounds, please do let us know. See you next time with another episode of Stroke Rounds. Thank you.